today by our keynote speaker. Let's listen to the following ground rules. One is that we should use the chat feature for general comments and questions. There is a Q&A icon. Please endeavor to post your questions using the Q&A icon so that we don't miss any questions. Also, you can raise hand if you would like to speak, but really encourage us to use the Q&A so that we'll work within the time that we have. And if you're having any technical issues, you can refresh your Zoom. And please note that this meeting is being recorded. And at the end of the meeting, we are going to share the recording and the slides to all participants. Thank you. So I would like to introduce us to our keynote speaker today. It's no other person than Dr. Prince Agwu. So he's a research fellow of the Ed Policy Research Group. Dr. Prince Agwu is an academic. You can see him, his video is on. So while I'm taking the citation, that's him there. He's an academic at the University of Dundee, Scotland, UK, and a research fellow at the Ed Policy Research Group, University of Nigeria. His contributions to the field are further highlighted by his service on the editorial boards of prestigious journals like Earth Research Policy and Systems and Earth Economics Policy and Law. With a PhD in social policy and extensive research experience, Dr. Prince utilizes his expertise in applied social and policy research to drive meaningful policy and systems changes that contribute to the health and well-being of populations. Join me to welcome Dr. Prince Agwu as he takes us as a keynote webinar on today. Thank you. You're welcome, sir.
Yeah, thank you so much, Dr. Bose. So yeah, I would now try to share my screen. Okay. Yeah, there we go. Okay, all right. Thank you so much once again. Thanks so much to the Federal Ministry of Health and Social Welfare, the Department Planning, Research and Statistics, for putting together this webinar on behalf of my team from the Health Policy Research Group, University of Nigeria, which is the National Center for the African Health Observatory Platform. So we currently put together the country health systems and services profile for Nigeria, and I'll talk about what that means. And this was put together by our team. The launch for this profile is going to be next week. So this is more like insights, more like a pre-launch against next week. So just to go over what the CHSSP is about, its content, and why the CHSSP is an important document and an important compilation for our health systems in Nigeria. So I'll go straight into my presentation. Dr. Bose, how many minutes do I have, please?
You have 25 minutes, sir.
Okay, great. Yeah, so that I can. So I'll try as much as I can to manage the presentation within 20 minutes. So here we go. So what is country health systems and services profile? You know, if you come to the European continent, as I'll show in the next slide, you would see that countries are making deliberate efforts to pull together sets of big data to sort of pass information as to what their health systems look like. So it's more like pulling together historical set of data and passing messages around what the health systems look like for these countries, and structuring these information across the health systems building blocks. And so you see deliberate attempts to pull data around service delivery, around health workforce, around health information, around governance, around financing, around medical products. And so the idea is to achieve an analysis of the features and characteristics of a country's health system, and looking across board, the reforms that have been happening within the system, and laying out these things very clearly, including the strengths and challenges across the health system's building blocks. We understand, and I think anyone who tries to play around data would understand how sometimes it may not be so easy to go through big data because of the much technicalities involved. So what a country health systems and services profile would do is to pull this big data together into something that is easily retrievable on one hand, and on the other hand is easily readable. So all of the big data you see, maybe like the global health expenditure by WHO, disability life adjusted years, all of these very big data that may not be easily comprehensible. The CHSSP tries as much as it can to pull this big data together in explaining where a country's health system is, how services are being delivered, and making sure that this data is converted information that can be used by policymakers, that can be used by academics, and importantly, that can be used by the public as well. The interesting thing with a country health systems and services profile is that the templates are usually standardized. So the template used in Nigeria will still be the template used in Ghana, will still be the template used in Rwanda, will still be the template used in Senegal. The idea is to be able to achieve some kind of cross-case analysis. So when you look at service delivery in Nigeria, you can make quick comparison with what service delivery in Rwanda looks like. You can make quick comparison with what service delivery in Ghana looks like. And so with the country health systems and services profile, you see that countries are beginning to have some kind of holistic understanding of where they are with their health systems, not just for their countries, but then to understand what happens, around the region, which provides the fundamental bedrock, to for cross-learning, and as well to understand where your neighbors are in terms of health systems performance and in terms of health systems growth. So these are examples of country health systems and services profile. In Europe, the CHSSP dates back to 2017. And I think between 2017 and now, they've produced two editions of their country health systems profile, because it's produced twice. It's produced biennially. So every 2 years, you see them produce like their CHSSPs. So by the end of 2025, we are looking forward to see what the country profile across the European continent would look like. So you can see on that slide, we have that of Estonia, of Slovakia, of Cyprus, of Finland. And these country profiles, it's usually an extension of what is published by the OECD called Health at a Glance. And you can see that on the European continent, country profiles are taken seriously because of the importance of cross-learning on one hand, and then the importance of having countries on the continents to look at what their neighbors are doing, which can sort of provide that platform for healthy competition. Of course, healthy competition would yield positive growth. So for the country profile that we are launching next week in Nigeria, what were the processes that we undertook. But before that, this slide presents what the profile is for Nigeria, and then the African Health Observatory, which is the engine room, so to say, of the CHSSP. Currently, we've been compiling these across 5 countries, 3 in East Africa and 2 in West Africa. So efforts towards pulling together these country profiles dates back to about 2021, 2022. And it's being spearheaded by the African Health Observatory. The Health Policy Research Group at the University of Nigeria is the national center for the African Health Observatory in Nigeria. So I think at the moment, there's presence of AHOP in Ethiopia, in Kenya, in Rwanda, and in Senegal. And so these country profiles are being published at the moment to reflect what the health systems look like in Ethiopia, what it looks like in Kenya, what it looks like in Rwanda, and of course, what it looks like in Nigeria. The profile being launched next week of the 5 countries, Nigeria is the first to complete its own profile, and it has been scheduled for launch next week. And so the fundamental idea behind the country profile is to see how we can pull together components of our health systems, towards achieving universal health coverage, and of course, other health-related SDG targets. And because, like I pointed out in the previous slides, this is not new, globally. It's happening in Europe. And so there are learnings that we have adopted to produce this profile for Nigeria, and of course, to produce this profile for the region. There are learnings who've been taken from the European Observatory, whose efforts on country profiles can be dated back to 2017. When we started this process in Nigeria, we took the templates. Recall when I said that to produce country profiles, the templates have to be standardized. And so we took the draft country profile template, the draft template of the country profile, to the then Minister of Health, Dr. Osage Ehanire. So he was the one who, together with the ministry, looked at what the draft template looked like, the objectives and the processes, that would be adopted to produce the country profile. And then the process was flagged, to go ahead to produce this profile. Afterwards, experts were put together to look at these standardized templates and reviewing available data to be sure that we have data providing answers to the content in the standardized template. Thereafter, we had an expert review, of data and filling up the profile template with several rounds of peer review within the expert team. And then thereafter, we had to do some double checking to ensure consistency between the data at our disposal and those, the data sets, that we have regionally and that we have globally. Some of these data sets, when you dive into the profile, you would get to see how they've been presented in a way that you can easily read and you can easily use, whether for policy making, whether for research, and all of such. And finally, when the profile was completed, we had series of external peer review comments, just as you would have, when a paper goes to a journal, for when you submit the paper to a journal and then it undergoes peer review. So in as much as the peer review for this profile happened iteratively, where at every stage, at every point in time, folks were looking at what was being done, and making comments, and making suggestions, and making edits. However, At the end of the compilation of the profile, we had to send out for peer review. And of course, comments came in, and the authors of each of the chapters, made several adjustments, and of course, looking at the health sector reforms within the space up until 2024, so we should note that. And at the end, we're here with the profile completed and now ready for the launch next week. Now, having come to understand, what profiles are and why we need to develop profiles, and the importance of those profiles for our systems, I would now go into looking at the chapters in the profile. There are 11 chapters, but then I'll speak to 8 of the chapters because the other 3 of the chapters are more like epilogue, looking at systems outcomes, and of course, looking at the conclusion of all of what we've written from chapters 1 to 8. So the first chapter looks at the overall context of Nigeria. It looks at the historical background of Nigeria. It looks at the population and demography, of Nigeria. And then it pulls all of these together, including the economic components, of Nigeria, GDP and all of such. And then it pulled all of these to side by side, to check how far, we are from achieving universal health coverage by 2020. It also looks at our population growth and how the population growth in some way tallies, side by side with our burdens of communicable disease and non-communicable diseases. And then the context also lays out background around various disease burdens, in the country, and how these disease burdens in some way relate with incidents of mortality. The next chapter goes into the governance structure, of Nigeria. Of course, 3-tier at the federal level, at the state level, and at the local level, and of course at the ward level. And it looks at how health providers fare across these levels, and how policies are as well designed and communicated across these levels. And then it also goes into looking at the power relations, power dynamics, politics and the influences, all of these structures get to have on our health systems, across the 3 levels. With the insights to seeing how all of this politics and power, how they pull together to either improve the health system or not to improve the health system. It also pays attention to coordination of the systems, down to the ward level, to provide comprehensive insight to seeing where we are in terms of governance of our health systems. And then it looks at providers' contributions to these governance structures, particularly paying attention to how these providers are regulated, and of course, how accountable these providers are to the provision of health services to citizens. And on the chapter 3, we looked at the money matters of our health system, and that's health financing. And important information around this, speaks to issues of health expenditure, out of pocket spending, and how OOP, that's out of pocket spending, government investments in health, and contributions of donors. So there, in this chapter, you would see the percentages of all of these components from the government, from private pockets, that's from the private pockets of citizens, from donors, how much percentage each of these guys, contribute to covering health expenditure in the country. And there is a down-to-earth explanation of what out-of-pocket spending means in this chapter, and how it's in some way isn't the best, for our health system. Importantly, in this chapter, is to look at the political will, of the country, especially in terms of the economy growth, and how maybe perhaps in spite of economic growth, so much is not being spent on health. I think, as we know, at the moment, health expenditure, to the budget it's about 5%. But then, if you look at the WHO data on global health expenditures, you would see in this chapter, you would come to see that a combination of all levels of government, the federal government, the 36 state governments, plus the FCT, and then the local government, when you pool all of what these levels of government spend on health, I think it's about 15%. And then citizens, spend about 79%, covering out-of-pocket cost, and then donors, spend about 7%. And if you look at that data and compare to what we have in some other countries, in terms of how much their governments spend on health. For instance, when you go to, I think, South Africa, the government spends about 62%, covers health expenditure, about 62%, of that. And that tells you that out-of-pocket spending will be somewhere, let's say, about 30% or so. I think in Ghana, the government covers about 55% of its total health expenditure. And then in Gabon, the government covers about 64%, of its total health expenditure. But when you compare that to Nigeria, you can see where we are, where the government across all levels cover 15%, of the total health expenditure within the space. And that speaks to political will. So one thing I really love about this profile, from my own view, it's how you see some kind of expert interpretations, to these issues. And these expert interpretations are made in such a way that anybody, everybody, can read and can understand, what these things are saying. And that's what we need, as far as our country is concerned, especially if we want health to become part of the indices, for our elections at some point. Chapter 4, it goes into the health workforce analysis of our system. And of course, health workforce spans across physicians, midwives, nurses, those in the laboratory, pharmacists, and of course, other allied health workers within the system. And this chapter did not just like you would see in so many other studies, where they get to see that Nigeria lacks a health workforce and everything. It goes beyond saying that, it goes beyond just making the analysis of lack. It, delves into what in recent times studies have been referring to as the paradox of surplus. And what that means is that you produce good enough, number of health workers, but then you have a poor absorption rate. I think if you read, there's a paper in BMJ Global Health, and you can as well see that reflecting in this profile on the state of health workforce, within the WHO African region. And I think that was published last year. The data shows that Nigeria produces, I think, about 2,000 medical practitioners every year, and then about 5,000 nurses. And this is not, it's not reflected of the other health workforce, like pharmacies, and community health officers and community health workers that we produce. So that's to say that just within the physicians, the physician profession, and then the nursing profession, in combined, we produce about 7,000, workforce every year. but then we have a poor absorption rate, because we don't take these guys, in, as we should, which also speaks to the quality of our health investments. So all of these analyses you find in this chapter, around health workforce challenges and how these health workforce challenges in some way or in many ways, impact our health outcomes. The next chapter, which is chapter 5, speaks to medical products, and health technologies. And you would see how it is properly laid out in terms of our abilities to produce medicines and health and other health consumables. And as you can see, that our national production meets just about 30% of the demand. I think with PVAC, the goal is to see if we can get to 70% by 2030. Yeah, so we're just 5 years, away from that. And looking at what PVAC, has been doing, there's some sense of hope and encouragement, that we would begin to scale up domestic production capacity to meet the level of demand of medical consumables within the country. And of course, we can tell what that would do, to managing cost of medicines, to managing cost of care in so many ways. Next is the chapter 6, which goes into health infrastructure, and equipment. And we can see that about 80% of our public health infrastructure is dysfunctional. And this, in some way, reminds me of something that happened recently, just on a light note. So I was approached by the UK court system to report something, about on health, because they wanted to make a decision on the case of a Nigerian in the UK. And so it's about a particular health condition. So I did my research, both primary, secondary research, and produced the report. And it should be somewhere in 2024, thereabout. So after a year, they came back to me to say that they felt like that Nigeria has the capacity, to address this condition, and all. And they didn't present like arguments. What they did was to present like fanciful builds, hospital in one of the states. I wouldn't make mention of the name of the state. And so when I looked at the picture, beautiful, brilliant, I did some Google image search, of that picture, and I could see that, it had even some fanciful, political headings, more like this infrastructure has been built to respond to health needs of Nigerians, and most of those political headings. And 1 year apart, I had to go back to do another research, particularly on that hospital and on that disease condition. And then I discovered that the results that I used to develop the report in 2024 were even better than the results I was finding, in 2025. And so the image, the guy sent me, very beautiful hospital and all. Just 2 days before that image came to me, there was a comprehensive report on that facility that even the private consultants they had hired, they've all left because of payment conditions, that the equipment, in the facility, weren't, optimal, and I think at several times, that particular facility was short. And the heading was more like, was it about 47 billion, naira something, sank into a health infrastructure that is not providing services. And so what the guys could now see that in 2024, on a particular health condition, on a particular health issue, looking at if we have the capacity to address, I had better reports, even though they were not so good. But then 1 year down the line, the report became worse, than the previous one had submitted. So that scenario explains, what this chapter, tries to bring out, that it isn't just about having the infrastructure and, doing all of the ribbon cutting politics, But then it should go beyond that to looking at issues, around maintenance, and issues around sustainability. We have the guidelines of medical equipment management, in Nigeria. I think it's 2005 since that policy document came on board, and I don't think it's been revised. In fact, it's even stated in this chapter, as well. And so we are hoping that, I think recently there was the launch, as even cited in this chapter, of the Nigerian Health Infrastructure Development Bank. Some thoughts are going around having Nigeria's Health Infrastructure Development Bank. And we're hoping that we get to see that come alive at some point. Next chapter, which is chapter 7, looks at a critical component of our health system, and that service delivery. And you can see that because of how these services have been, and all, we're having more persons, going to patronizing traditional healers, traditional birth attendants, and all. Of course, we have all of these targets, in terms of scaling up patronage of skilled health workers, scaling up patronage of skilled birth attendants, and all. All of the data you need to understand these issues, are captured, in this chapter 7, of service delivery. But the interesting thing within the Nigerian system, as this chapter relates, is that there are strong level community structures, to see how we can regulate, and we can work with, provide, healthcare services across the board, even from our traditional healers, from the formal health workforce and everything. And as we can see also in this chapter, there are citations around how we can go about linkages, and where we are with linkages in terms of pulling the informal health workforce, into the formal health system, such that we can achieve, very sound regulations, over the informal health workforce. And so that they can become, of course, an extension of the formal health system, as we all already know it's happening. And that way we can be able to regulate for scope, we can be able to regulate for quality, and then we can be able to regulate for an efficient service delivery. And one of the game changers within the system in terms of service delivery, of course, is the Basic Healthcare Provision Fund. And as stated in this chapter, the Basic Healthcare Provision Fund, it's doing well in terms of seeing how we can increase our pace, at achieving universal health coverage, which is just 5 years away. But however, the chapter warns that caution should be taken, against all of the implementation challenges that have marred series of policies and programs, before the Basic Healthcare Provision Fund. And finally, based on 11 chapters, but we're talking about 8 chapters, for this pre-launch insight. So finally, health information and information systems. As we can see, Nigeria has an established National Health Management Information Systems Policy. Of course, we all know about the DHIS, and how that has been very effective to some extent. However, this chapter looks at all of our manual reporting, especially at the facility level, if you go to the primary healthcare facilities, how all of these manual collection of health data and everything, to a large extent affects the accuracy and reliability, of the data, we pull into the DHIS, usually at the state level. So the hopes around all of these is to see how we can rejig the health information system space in such a way that we can begin to have real data collected from the levels of communities in such a way that human interferences, are not so much, which to a large extent, would increase the reliability of our data, the accuracy, of our data, and of course the trustworthiness, of our data. So fine job doing so far in terms of health information and information systems, but more has to be done, especially around subjects of digitization, and capacity, to pull this data, from the facility level into our information health system. So hopefully, we know that at some point things may begin to change. We're already beginning to see some of the changes happening in the system, and all. So in all, country health profile, has come on board, at this point. This is the first, so far within the Nigeria's health space that provides historical compilation of our data, comparable compilation of our health systems data, so that we can be able to look at where we are and look at what other countries are doing, and we can be able to cross-learn, and we can be able to healthily compete, as well. And so going into in the rest parts of the year, we know the joint annual review will be coming up hopefully this year. The National Council on Health would as well be coming up hopefully this year. That the State of Health of the Nation report, one report I love so much, will be coming up again this year. So the CHSSP has now provided like a one-stop shop reference material for all of these activities: NCH, the JAR, and of course the State of the Health of the Nation report. So you can now have that one place to go to look at, to say, where have we been since like 2020 up until 2024, and then use that to make your analysis, across the various health systems building blocks. And importantly is that, like I said earlier, this is like the first, and we're hoping that going forward, that Nigeria and the African region, just as I showed earlier, as happening on the European continent, where every 2 years countries produce their health systems and services profile. We're hoping that culture, will be sustained in Nigeria and in the African region. And of course, the African Health Observatory Platform, the Health Policy Research Group, would be there to support the processes, in order for Nigeria to imbibe, and sustain this culture of producing country health systems and services profile over let's say 2 years, or over 3 years, or over 4 years, as the case may be. On the European continent, it's once in 2 years, but we can start from somewhere. So at this point, I would now show you AHOP has been active within the Nigeria's health system space, and you can see the various products. This is just a few, of the various products coming from the African Health Observatory Platform in Nigeria. The same is happening in Rwanda. The same is happening in Senegal. I think across the 5 African countries, as I mentioned earlier, including Ethiopia. So on behalf of the Health Policy Research Group, the African Health Observatory Platform, the Health Ministry, which now has incorporated social welfare, and then the World Health Organization on the African region, I'm welcoming you, to the launch of the new country health system and services profile for Nigeria, the first, of its kind so far. And it's happening next week, October 8th, 2025, happening at Bolton White Hotel, Abuja, Nigeria. You can scan the QR code and it takes you to the fully published profile. So where you can, spend time, look at all that we've done, across the 11 chapters, across the 6 health systems building blocks, and that would give you good insights and comprehensive image, of our health systems, where we are, and of course, where we aspire to be in the coming years. And so from my team, you can see all their beautiful faces and handsome faces. I'm saying thank you. For email, you can email us at hprg@unn.edu.ng. You can follow us on LinkedIn, Health Policy Research Group, UNN. And then, of course, you can search for the African Health Observatory Platform across social media and platforms. And of course, the Integrated African Health Observatory, that's the IAHO. So thank you so much for listening to me. It's a pleasure.
Thank you, Dr. Prince, for the insightful presentation. I'm sure that everyone is looking forward to the full launch of the of the profile. I'm also looking forward to that. So in the last few minutes, Dr. Prince had taken us through the CHSSP and what it's all about. But my own take home is that it simplifies the big data and makes it easy for the public to comprehend and also makes it easy for decision making. Thank you very much. Please, to our audiences, we want to thank you for joining us this morning. We have participants from across the country, in fact, across the globe. And I would like us to put our organization beside our name so that it can be easier for us to identify you and for us to also identify you properly. I want to appreciate the presence of our directors that are here with us, CEOs from our various hospitals, and also staff of the federal tertiary institutions across the country and other colleagues. Please do well to put your organization and see your anchor for this program, Bosede Arogundade, and I head the coordinating unit of the Department of Health Planning, Research and Statistics. Shortly, we'll be going into the Q&A. We already have some questions here. In case you are not able to take all your questions, please try and make it to Voting White on October 8th to be part of the launch of the country health system profile. Thank you. So the first question said, would you send a soft copy of the document to the mailing group after the launch next week? I think that has been answered. In fact, the profile is already, the book is already available for us. Just scan the QR code and you will have it. Then somebody asked, quality data gathering is critical to this work. What are your experiences and recommendations to the country? So you may want to speak on that. The other question is, Nigeria is 36 plus 1 countries. So to say, how can this information be decentralized to engender in-country positive competition and minimize white elephant projects that you described? Then another question said, do you see PVAC moving the needle around medical products, knowing fully well that this is beyond the Ministry of Health? Good review. I hope this review PowerPoint presentation slides will be shared to our email boxes. Yes, you'll receive the PowerPoint on the email on our feedback and also the recording of this presentation. That's all the questions we have for now. Please, for those that are raising up their hand, you might want to send in your question because we may not be able to take that. We have less than 10 minutes to end this session. Dr. Prince, over to you, sir.
Okay, all right, yeah. So Professor Enyi Etiaba is here, who is also part of the team. So I don't know if she had some of the questions and she would want to take some of them. Prof.
Good afternoon. Good morning, everyone. Yes, I heard the question. I'm happy to be here. Thank you very much, Prince, for a perfect delivery and concise summary of the profile. The first question, if I recall, is whether we're going to send the profile to the email. And Dr. Bosse already answered that. If you scan the QR code, you would it takes you directly to a soft copy of the entire profile. For those who are old-fashioned like me and would like a hard copy to hold on to, if you attend the launch, we'll see if we have enough copies to go around. The second question, I'm sorry, I think it's about data. Sorry, Prince, remind me, what was the second question?
So the second question, it's about quality data.
Yes. Yeah. So quality data and data management and transmission remains the big elephant in the room in the Nigeria and in all the developing countries. The length of time it took us to produce this profile was contributed to by us, wanting and looking for data to update and to make sure that it's up to date and current. So it's an ongoing problem. We do hope that the recommendations in the profile and the steps we took would help to hopefully improve to a certain extent how we manage data and at least create an awareness about the importance of data. In terms of the profile being an overarching profile, yes, it serves as a template. I know a couple of states have already indicated interest on how to produce a state-level health systems profile for them. The idea is that this serves as a template to see, as a Prince, succinctly put it, how data is arranged, the processes. So the process on its own, it's a manual, the process of developing a template, which states who are interested could get experts to develop a state-level profile. In the same way that we step down the strategic health development plans, the 5-year strategic health development plans, you have the national and then the state ones, the 5-year. So the idea is that this forms a one-stop place for data that can then be translated to the state level, adjusted contextually to different states. And like I said, any state who's wanting and interested to have a state level health and service profile is free to consult, and we can have further discussions on that. We think it's something worth doing. 2 states have indicated interest already because it is really 36 plus 1 countries and not 36 states. Thank you very much. I think there are 2 more questions, which I hope maybe Prof. Obi or Prince or any of the other panelists can take. Thank you.
Okay, yeah, thank you, Prof. So Prof, you've done justice to the question on quality data, decentralization, and slides. So I think so the question left is that of PVAC. So I wouldn't be in the best place to begin to tell you if PVAC has the capacity, or let's say the magic wand, to have things going, for us, especially as regards improving the value chain within the health sector and increasing our domestic production of health consumables. But then, when you look at the information within public space, around PVAC, you tend to see some sense of hope. I think notably it's the $1 billion MOU signed between the ministry, PVAC, and I think the Afrexim Bank. And I know that there has been, I wouldn't want to say release, but I know in the news you would see, I think about $75 million term sheet has been committed, to that process already. So when you look at the information within public space, as regards the intentionality of improving our domestic capacity around production of health consumables and medicines, you get to see some sense of hope. And so we hope that they carry on with that fire, and with that momentum into the coming years. And then the other question around joining the health policy research group. Yeah, so just send me an email and then we'll take it off from there. Thank you so much. Dr. Bosede, over to you, please.
Thank you so much, Dr. Prince. Thank you, Professor Etiaba, for the answering the questions. So we know that the Health Policy Research Group, in their presentation, they did not work alone. They were supported by the World Health Organization. And we have here with us Dr. Mary Brantuo, the team lead for universal health coverage in WHO Nigeria. So we'd like her to give us a remark from WHO. Dr. Mary, please.
Thank you very much, Dr. Bosede. And let me start by appreciating the excellent presentation that has been made by Dr. Prince, which has been very it has summarized in a very excellent way the document which we have before us. I have a copy of the document right here before me, and it has really summarized it in an excellent way. Thank you very much, Dr. Prince, for that. Also would like to acknowledge all the team that worked on this, producing this document. We know it was a partnership between WHO and the team that was just the health HPRG group. And I know some of my colleagues in WHO did this way. Appreciate for me. We have had the details that are provided in terms of the from looking at the health service delivery, in particular the description of the institution that Dr. mentioned. So all of this, we believe that and that it would help us in looking at the evidence to see how can this help in our planning? How can it be put into to strengthen our plans? So for WHO, we see this as a very positive development. And as he had mentioned before, it was something that WHO started with a few countries. WHO has been working on the health observatory in a number of countries for some time now, trying to bring all the data products in one place to make data easily accessible. And this is supposed to help in evidence-based planning. So we really appreciate the work that has been done by the team to bring all of this in one place. And we know that it will really help for planning, but it will also help in generally strengthening the system in Nigeria. So we really, really would like to congratulate the team. For us in WHO, we would continue to stand by to support in disseminating this. Also we've had the requests that have come up about looking at the states. So we also stand by to see how we can strengthen this approach, looking at the different states, taking this up further. So thank you very much for this opportunity, and we congratulate the team once again. Thank you.
Thank you, Dr. Mary. Thank you so much to the team for putting this together, and we are really looking forward to the launch of the country health service profile. So we have other questions that came up at the end of the last one. We will not be able to take them. However, we'll note this question for the main activity next week. And I want to encourage the participants that dropped the question that they might want to come to Abuja to really ask their question again live to the to the experts that put this together. And also, I'm sure at the event next week, the minister and the top management of the ministry will be there, and they'll be able to provide answer to what the ministry is doing and some other questions that have been asked. Thank you so much for making it to our webinar today, and we're expecting other agencies, departments, and other people working in the health sector who has something to tell us. You are doing something and you want us to help you announce it or make it known. This platform is available. Just reach out to us in the Department of Health Planning, Research and Statistics. I'll be able to give you a date. Thank you so much for joining us today. See you again in 2 weeks' time. Thank you. Merci beaucoup.
Thank you so much, Dr. Bosede. Thank you so much, everyone.
Thank you. Bye. Bye.